Okay. Well, good morning, everyone. Thanks for coming so early. And I have a few things to Zoom for the Zoom. Let's see. Let's see. What is the Zoom? Oh, what were relevant to our surgeries coming up this week, and a couple of techniques that can be helpful for difficult cases. The first thing we were going to talk about was capsular tension rings. And so why Why might you need a capsular tension ring? Well, capsular tension rings are used when the zonules that hold the lens in place. And as you know, there's right behind the iris is the lens, and it's held in place by all these little zonular fibers that connect the equator of the lens to the ciliary body and allows the lens to move when we're young and accommodate. And those fibers are important during cataract surgery because if they're weak, it can cause the lens that we're breaking up, the natural human lens, to be loose, can even fall back into the vitreous cavity. And also, those fibers are dependent on how we depend on those fibers to hold the artificial lens in place. And so we need those fibers to be strong for the surgery. And there's a number of reasons that we might have trouble with those fibers being weak. Certainly where we are probably, and probably here too, pseudoexfoliation syndrome is one of the common reasons for that. Um, uh, previous trauma in the US, airbag injuries are a big thing. When the airbag hits the eye, it squeezes the eye in this direction, stretches the eye in the other direction, and can cause those fibers to tear. If you ever see a patient that you're doing cataract surgery on who has had some sort of car accident and you notice their pupil is bigger on that side permanently after the trauma they had, they're probably going to have zonular damage because when our eye gets hit from the front, since it's in a bony orbit, it doesn't have any really where to go back. So it gets squished this way, which stretches it out the other way. And anything that's a circular structure inside the eye gets stretched and can get torn. So the iris will get torn, the zonules can get torn, ciliary body can get torn. Patients that have very high myopia, so very long axial lengths, often can have problems with zonular weakness. And then nowadays, with patients getting lots of intravitreal injections or previous pars plana vitrectomy surgeries, it's not uncommon if the patient moves during surgery or during the injection that there's some damage to the lens fibers there too, the zonules that hold it in place, and also can even have trauma to the lens. If you ever see a patient that has been getting intravitreal injections and say within a week or a month after one of their intravitreal injections, they suddenly have a really bad cataract, it's probably because the lens capsule got torn by the injection, and that's going to be a really challenging surgery, no doubt. So one way we can help with zonular weakness is using endocapsular tension rings, or we just usually call them capsular tension rings. And these can provide support for the weak or missing zonules. And there's three different types of capsular tension rings. A standard capsular tension ring, which is good for up to maybe 3 or 4 clock hours of zonular weakness. So we kind of think about how much zonular weakness. We often describe it in clock hours. I guess you could use degrees too. But 3 clock hours would be about a quarter of the zonules missing. 6 clock hours would be half. There's also the Cioni modified capsular tension rings, which we'll talk about, which are good for larger amounts. And nowadays, we most commonly for severe zonular weakness, we use the Ahmed capsular tension segments. So capsular tension ring, the standard capsular tension rings look like this up here. They're a ring of plastic, polymethyl methacrylate. So if you have hard, rigid, non-foldable IOLs, like for example, we use for our anterior chamber lenses, or we use them for our sutured in lenses, are made of that same material, the same material that the first lens implant was made of. It's this polymethyl methacrylate. They lots and lots of different companies make these, and they usually come in different sizes, which is basically the diameter of this. And probably the most common size we use is a 13. You can use smaller rings if the patient is, for example, hyperopic, or you think their eye, the axial length is shorter and the eye is going to be a little smaller. And you can use larger rings if the patient's more myopic or has a larger eye. The smaller ones tend to be easier to put in. So if I have one case where I think it's going to be difficult to get the capsular tension ring in, I'll often use a smaller one. One important thing with capsular tension rings, you have to have a complete intact capsulorhexis. So you can't use these if you're using like a can opener capsulorhexis, or if you have a nick in your capsulorhexis. If you put this ring in and expands out the capsular bag, it will cause that tear to extend. You also have to have a intact posterior capsule. I suppose if you had a nice round opening in the posterior capsule, you could consider one of these, but usually you'd want to make sure both the anterior and posterior capsules are intact. In the US, these first became available in 2003, and they can also be injected in. And we'll show you a little bit of that. The standard capsular tension ring sits in the capsular bag and pushes the capsular bag outward, but it really doesn't do anything to give you more zonular support. So it's nice if you're missing some zonules in a certain area, and the capsular bag is collapsing in that area, and you're worried it might decenter your lens. You can put the capsular tension ring to tension that area of the capsular bag outward and make the capsular bag nice and round again. But if you are missing, say, 6 clock hours of zonules, you're missing half your zonules, and the lens is starting to tilt in this way, the capsular bag is starting to tilt in, those won't really do much to help you. And so in a few years later, after the first capsular tension ring was made, Robert Cioni, who's an ophthalmologist in the US, developed these modified capsular tension rings. And they have these little eyelets on them. And so what you do is you put this into the capsular bag, and then this little eyelet that has a loop on it extends out over the capsular bag, and you can use this to suture. So if you can imagine, if you were missing zonules on this side of the eye, these 6 clock hours of zonules were missing. If you put this capsular tension ring in, this modified capsular tension ring, and used a suture here to the scleral wall, it would help support this whole side and give you much better support. So these can be used for almost any amount of zonular loss. The single eyelet ones would be good for about 6 clock hours of zonular loss, but there's even ones with 2 eyelets on them. And you could use this to support if you even had complete zonular loss. These can be used somewhat through an injector. The eyelet won't go into the injector, so you could put this into the injector up to about this point, and then it won't go in any further. This one you couldn't do anything with. It does, again, require an intact capsulorhexis and an intact posterior capsule. Here's an example of one in the eye. So this is a patient whose sister threw a Barbie doll at her, and it hit her right in the eye and ruptured her globe, and she lost a lot of her iris and had a bad cataract. But it's kind of a nice example because there's so much missing iris, you can see the capsular tension ring in here. So this is the capsular bag is here. This is a Cioni modified capsular tension ring. So here's the 2 ends of it. So this capsular tension ring here, this eyelet is going all the way around in the capsular bag, coming around to this side. Here's the eyelet that's attached, coming off like this. And here's the other end of the capsular tension ring. So that's how the normal capsular tension ring sits in the eye. There's usually a little overlap like that. And then here's the anterior capsule here, a capsulotomy that we created. And this eyelet is coming from inside the capsular bag and looping over and kind of kinking the anterior capsule here. As it comes out above the capsule, there's the other eyelet. And what you can't see is there's a suture here holding this in place. And then you could put a lens implant in the eye. And you can see, if you look at the center of the cornea, the lens implant's pretty well centered. Obviously, she's missing a lot of iris here, but she has a pretty nicely centered lens implant there. The Cioni modified capsular tension rings are a little bit difficult to put in. These eyelets here need to be positioned in the correct spot. And so when you put this in, inject it into the eye or feed it into the eye with forceps. This eyelet isn't always in the exact right spot. So you may need to move it around here and slide this whole ring around. in the capsular bag, which already has a lot of loose zonules in it, and that can cause even more zonular loss. So we don't use these too much anymore. We've kind of gone now to using these Ahmed segments. So Ike Ahmed is an ophthalmologist, glaucoma specialist who came up with these segments. So it's basically just a piece of a capsular tension ring with an eyelet on it. So you have just a segment or piece of that capsular tension ring that has this eyelet. And these you can put in, so these you can put in the capsular bag wherever you want, and you don't have to feed them in like you would with a normal capsular tension ring. And they're very easy and gentle to put into place. And I can show you some videos of these too, but they're much easier to put in. So how does a capsular tension ring go in? This is an example of one, just a standard capsular tension ring using an injector. And I think the ones we have don't have an injector. So I kind of like doing it without the injector. I think it's a little more gentle, but the capsular tension ring feeds in like this. And you don't want to go straight in if you, for example, pause this for a second here. If we were to go straight in with this injector in the middle of the eye, and this capsular tension would come out, and it would come out and going just perpendicular to the bag, it'd be just poking right into the bag. And if you continue that way, it can puncture into the capsular bag. So we want to aim as far off to this side. So when this injector, when the ring goes in, it comes in as even with the equator of the capsular bag as possible. It goes in nice and smoothly.
Sir, how about having a second instrument from the left side so that we can support that and push it downwards?
Yeah. So what a lot of people do, for example, one of our residents I know likes to do this when we put capsular tension rings in. They'll come in with what we would call a Sinskey hook. You probably just like a dialer, basically. And they would have inject from one side and have a dialer hooked into this tip here. And then what they do is you can pull that inward to curl it as you inject in, and it makes it a very gentle curved input as it goes in. And so that's really nice to do with the injector also. You could also put a loop of suture from an incision over here, put a loop of suture through here in this direction and pull on that loop of suture, and that will curl the end and make it a little more gentle entry.
And one more thing, sir, we do that in initial days, if you are not sure whether if it goes to sulcus and all, we just put a suture and then we put it inside. If you are not sure that it went into the bag, we just pull it out again and we can retag.
Yes, that's exactly right. And I'll show you that in the next video. One of the troubles you want to when you put this in, you want to absolutely make sure it goes into the capsular bag, because you'll see when it goes in, once it goes in, you can't see it at all. And so there's no way to retrieve it. It's in there. And if you accidentally put it in the sulcus, there's no way to get it out of there. As you want to watch as you're going around, watch the capsular bag, make sure it's not being pulled or dragged, because these can puncture the capsular bag. And the end, you can see, it just has a little hook like a dialer on it. And then you want to make sure it's definitely under the capsular bag. It's not going to zip out into the sulcus.
Oh.
And then you can see it, can't see it at all anymore. So,
I mean, is this comes with this injector preloaded?
We have preloaded ones. This is an injector you can use to load any capsular tension ring into.
Okay.
But a lot of the ones we have now come with like a plastic preloaded injector. And I think it's so some of the things we talked about can be injected or be placed with forceps, which is what we'll do. And I think putting them in with forceps is the more gentle way to do it. I often will do it if I have a really loose zonules. You can use that 10-0 nylon. We usually use 10-0 nylon, a leash to help curl the tip. It allows to retrieve it. And then the question is, when do you put the ring in? And in general, you want to put the ring in as late as possible. Okay, so if you can ideally put it in at that situation where your cortex is already all removed, you can put it in early, but it can make it's hard if the nucleus is still in there, it can be hard to get it in. If the cortex is still in, it will trap the cortex in there and make the cortex more difficult to remove. So you would like to put it in as late as possible. Here's a case one of our residents is doing, and you can see this lens is really loose. So you know you're in deep trouble at this point. The lens was so loose, we decided to put in a modified capsular tension ring, the Sione style in here. And we're going to use that 10-0 nylon leash here, one, to help feed it in, and two, if we run into trouble, to retrieve it, because there's a good chance this whole nucleus might fall into the eye. And if it does, obviously retina is going to have to deal with that. But so you can see how you can use that suture there to curl the tip as you inject it in, and makes it go in a little more gentle. But you can also see these cause a lot of zonular trauma as you're injecting them too. You're probably
that one is holded by the assistant.
Usually the surgeon will be injecting with one hand and pulling with the other hand.
And the sutures, who are holding that?
It's just hanging outside the eye. So yeah, usually the sutures would be held by the primary surgeon too.
Yeah, it is.
So in this case, we kind of left that eyelet out there. And then you can just leave that suture out there, but you can use that to potentially retrieve it. And you can see it's difficult to get it in there with the nucleus still in there. But this one was so loose, we were afraid it wasn't going to make it through otherwise. So here we are at the end, posterior capsular tore, dropped a nucleus, but we don't want to leave that capsular tension ring in, which you can't even see at this. We can actually see the eyelet there, but so this is that 10-0 nylon suture. And we're just going to use that to retrieve that capsular tension ring and at least get that out of the eye. I'm not sure how the retina surgeons would get one of those out of the eye. You'd have to make a pars plana incision and somehow spin it out. So. I'll show you a video here of how to use. So this is a pretty loose lens. This is a Marfan's patient, of course, that has significant zonular loss. And he's featuring capsular tension ring support right out in this area. And so we're creating something called a Hoffman pocket. I'm going to get our capsulotomy done here. And I'm going to use some iris hooks. Capsular hooks are better for this than iris hooks. I'll show you a case with some capsular hooks too. We're going to use this to kind of help support that. You can see that interesting with the Marfans, the zonules are still there. They're just really stretched out. So this is a early teens age patient. So the whole lens out. And then we're going to take a suture here and dock it into a 26 gauge needle. This is some 9-0 proline suture here. That's going to come through the sclera. And then we pass the second suture through, and this suture is looped through one of these Ahmed segments. So you can see how easy this Ahmed segment is to put in versus that big giant Sione modified capsular tension ring. So we kind of put that in there. And then we always put in a capsular tension ring in this eye also to help keep the zonular support all the way around. And then the capsular. So this is feeding it in with forceps, and this is kind of, I think, the most gentle way to do it. So you're going to have 2 forceps here and just kind of hand over hand feed it in like this. And then maybe tuck the last part in with a dialer. You want to make sure it goes definitely under the capsular bag. I've seen once where it went into the edge, went in the sulcus, and then because that part of the sulcus unzipped the whole capsular tension ring, the whole capsular ring jumped into the sulcus. And that can happen if you have a really big capsulotomy. And you can see it ends up with a nice, pretty well-centered lens. Okay. Well, any questions on that? And you guys do have some capsular tension rings here, the standard type, which are definitely what you want to start with. Let's get rid of this. Since we're kind of on this topic, let's do this next.
Sir, one question on
Yeah.
this. Like suppose, depending on the location, what is your preference of inserting the CTL? Like suppose one is at the inferior, another one is at like probably on the right side or left side or superior. What
Yeah,
is
so
the location of entrance?
good question. So when you put a capsular tension ring, you can either feed it in with the tip going to the left, of course, or you can feed in the tip going to the right. And so I usually like to feed it in if I feel like there's weakness of the zonules on one side, I'll tend to feed it in toward that direction, just because I feel like if the zonules are weak over here and I'm feeding it this direction, as it's pushing on the capsule, it's pushing this direction and maybe causing the zonules to be even weaker or tear more of them. So I would tend to cause it to, as it hooks around, go toward the area of zonule weakness so that as it's dragging against the capsule, it's pulling against the strong zonules. If it's kind of loose everywhere, or say the zonules are loose down here and you're not going to be, either way is going to be equal, then I'll probably feed it in to the side where I'm going to deposit it, where it has maybe the smaller capsulorhexis size, because I want it to tuck under that capsulorhexis. And if it's smaller there, it's easier to tuck it under than if it's really big in that area. It might slip out into the sulcus.
Also, we'll have the better stability if you have the coverage.
Right. So here's a patient that I did surgery on the week before I left on my trip. It's probably not a good idea to do a case like this like for a trip. But this is I'm sorry, what's that?
Oh, you have shared the last
thank you.
presentation.
Let's do
Share
that.
the entire presentation.
Okay, let's go. 10, Zoom, share. Going to, this one here, I think. Thank you for letting me know.
Yes.
Okay, great. So this was an 83-year-old Russian-speaking woman who complained of poor vision in her right eye. She has a history of pseudoexfoliation syndrome. She had cataract surgery done about 5 years ago in her other eye. It was complicated by loose zonules, vitreous loss, anterior chamber lens, then had cystoid macular edema after it, but ended up with pretty good vision. On exam, she is... So in her right eye, she's 690 in vision. Her other eyes, sorry, I didn't convert that one, but almost
6.75.
6.75 vision. Her slit lamp exam shows in the right eye pseudoexfoliation on the lens and the iris. She only dilates to less than 5 millimeters, so about 4.5 millimeters. And she's got a pretty good cataract in that eye. And her left eye has a well-centered anterior chamber lens, but an oval pupil on that side, which bothers her. So here's a picture of her eye, fully dilated. And so what concerns would you have in this lady? What concerns wouldn't you have? I mean, pretty much everything concerns me. One, her age, so her cataract's probably going to be pretty dense. Two, that they had trouble with the other cataract surgery, and you know that this one is 5 years denser than the last one was, so it's not going to be any easier than the last one was. And if you ever see someone who's had trouble with cataract surgery in their first eye, I know when I was starting, I would think, oh gosh, what did that surgeon do? I can't believe they did that. My surgery is going to be perfect. And then I'd go do the next eye and I'd find out it was a really tough surgery. And I'm like, oh, that's why they had so much trouble with that first one. And so now whenever I see trouble with one surgery, particularly since I knew the surgeon who did this was a really good surgeon, I'm like, okay, this is going to be a tough surgery. The other things for us is, she's Russian speaking only. So communication during surgery. If the patient starts moving, you're not going to be say, hold still. You just hope they stay still. We can try to bring a translator. We have these iPads that have translators on them that we can try to bring in and talk with them. But again, that's another whole issue. She doesn't dilate well. So, and soot exfoliation syndrome a lot of times can be just a normal surgery, but considering the trouble they had in the other one, we're probably assuming this isn't going to be a normal surgery. So, and I edited this video down to make it a little bit faster. It's still long. So I did her with we usually do a lot of our surgeries with just topical drops, but I did her with a retrobulbar injection just because I thought there was a good chance we're going to need to do more than just a normal cataract surgery. So we're starting off normally. We put in a combination of lidocaine and adrenaline in the eye to try to dilate the pupil a little bit more. And then with a viscoelastic, it's always better to have a larger pupil. I think sometimes don't dilate really well, and that's not terrible dilation, but it's nicer to use iris hooks because you can put the hooks in the capsule if you need to, but I really don't like using iris hooks. So what I'm doing here is elevating the iris a little bit off the lens using some viscoelastic. So put a little under here. And this helps if you're doing iris hooks. It also helps if we're doing what I used was a Malyugan ring.
AC also looks a little flat, right, sir?
Yeah. So this is a Malyugan ring. So this is just another way of expanding a pupil. And so it has some advantages. It's much faster to do than iris hooks. It doesn't pull the iris forward like the iris hooks do. It also makes a more round pupil because instead of just fixating at 4 points, it fixates at 8 points because of how these scrolls go, the scroll grows from the top to the bottom. So you can see right here, it's also pushing the iris out. And that's why you get a much more round pupil than just like a square you get. The trouble with them is you can't make the pupil as big as you want to be because it's only the size of the you can make if you want to. So here's I probably should have used trypan blue on this, but I thought I think my view through the microscope was a little bit better. But you can always see the lenses moving a little bit. Here's where I'm wishing I used trypan blue. Why didn't you use trypan blue? The nice thing about the forceps are if you get a grip on the capsule, you can just keep going with it because you have it in rather than every time with a gauge. So here's where I'm really wishing I used trypan blue. All of these cortical. But you can see that lens as you pull with it moving a little bit.
From the very beginning.
So I knew, yeah. And that's when you usually will find out when you start your capsulotomy. If it's bad, that's when you're solidify how loose it was when I started hydrodissection here. So these are challenging because you want to make sure you have a really good hydrodissection because you don't want to have this lens difficult to rotate because if it's difficult to rotate, you're going to really stressing the zonules. And but you also don't want to do too much hydrodissection that you're going to cause a lot of stress on the capsular bag too.
Sir, that hydro cannula, the tip of that hydro cannula looks like a little dusted, is it?
Yeah, it does look dusted. I don't think it is, but it does look dusted, doesn't it? So you got that to pop up a little bit, trying to push it back in. So seeing if it's rotating here. And you have to watch the capsule closely with this because you might be pushing and you might go, oh, it's rotating great. And this actually the whole lens is moving because the zonules are so loose. So you can see here, I'm starting with a sort of it's going to start with a stop and chop because I knew this character was pretty dense too. And as I started doing this, I noticed that just the vacuum from even the low vacuum from the grooving setting was pulling the lens in a little bit. So try to prevent that extra stress. I helped support the lens a little bit while I was doing the grooving, so it wouldn't pull the lens back as much. I think these cases are even difficult as an SICS too, because they can probably an intercap would be the best way to do this. Grooved a little bit more. And then we'll start doing a little cracking here. I think I got it deep enough, so we're going to try to do a little bit of a crack here. So we're able to get the nucleus to rotate a little bit there. Everything's still pretty well centered, so that's good. You know, it hasn't like drifted off to the side or um, come really loose yet. Well, let's see if I can. Now we're getting a better crack there. Partially cracked. Let's go. So, and I think right about, let's see. As I was going to try to rotate it as little as possible, just to put less stress on the zonule. So I'm just going to try to go over to the side and chop a piece off. We got a little piece here. That's good. You can see the lens really starting to move now. I'm kind of chipping away at that thing. So making sure I got a full crack there. Now we're going to see if we can rotate it over and maybe chop another piece off. Seems like it wants to rotate a little better the other way. I'm going to see if I can grab this piece here. Kind of chop another piece off here. And then look at that.
Looking back.
So you can see the bag's intact. That's just the edge of the capsular bag. So there's so much zonules you can see. So then I know we're really loose. And so I'm going to we have these capsular hooks. I'd never used them before. So this is the first time we had them. We have some old ones that were metal and they didn't work very well. So we never used them. We just gotten these demo of these capsular hooks to try. So I thought I would try them on this case. So they're kind of like iris hooks, but they have a much longer hook on them. And the edge of it's kind of rounded to hold out in the equator. So you'll see they come in, I think I think packs of 5 again. So you can see it kind of looks like an iris hook, um, but it's got that much bigger. So the idea is instead of just hooking the anterior capsule like that other Marfan's case I had, just was holding the anterior capsule, it didn't do anything to help the equator. This hook goes way out in the equator and holds the whole equator of the bag out there better. They're pretty big, so they're a little challenging to get in. And this is the first time I've ever used them, so. And then these are supposedly the Chang modified ones. The earlier ones have a big loop here. And one of the concerns is usually you're going to use a capsular tension ring in these and then feed the capsular tension ring, and the capsular tension ring come in and go through this little loop here. And then you have a capsular tension ring here that's trapped the iris hooks in, and then I don't know what you do in that situation. Try to cut a piece of it off and maybe have the rest of it flopping around in here. So the idea was this is they made this loop small enough that theoretically a capsular tension ring won't go through it. So you can't catch it in there. So this goes out in the equator in there, and just like a normal iris hook, you slide this little plate down to hold it. And I'll kind of fast forward a little bit to, I ended up putting 3 of these in here, and you can see how loose that bag is. And these ended up stabilizing the bag really well. So now we got 3 of them in there, and now we're not seeing the edge of the capsular bag like we were before, the equator of it. And we're able to kind of proceed on more normally after this. And I'll go for it a little bit faster here, get through some of this. So did end up getting this out, and then they do trap the cortex where they are, so it's a little hard to get the cortex out in that area. You can see in between them, there's still some looseness of the capsular bag there. And you can try to loosen them up a little bit to get it out. So at this point, I had some cortex that was trapped in there. So I thought, well, let's see if I can get this out and then get that last little bit of cortex out. So I took these hooks out. But you can see that capsular bag is really loose. And this will kind of show you how well these hooks work. Because I'll show you how much. And you kind of fold them out like this. At least that's what I did. That's the best way, but they're a little too rigid to just like pull out of the eye like we do with the iris hooks. I'm going to use just a BSS can to pull some of this cortex out. But basically the whole bag starts coming out as I do that. So the last one out, again, trying to get some more cortex out of the whole. No reason to try to save this bag at this point. I mean, you could try to put it into and all that, but this bag is gone. So I just said, the whole capsule out. And it just comes out with forceps. So there was nothing left supporting it. So we'll take this Malyugin ring out now. What I probably cut out of the video is checking to make sure there's no vitreous coming out about 5 different times. So at this point, option would be to suture a lens implant in, which is a kind of a big deal. And I hadn't pulled a specific lens to suture in there. Or we could put an anterior chamber lens in. And that's what she had in her other eye. So I figured that would probably be the easiest thing to do. So what I'm going to do is, again, check to make sure there's no vitreous or anything available here at all. I'm going to put a little viscoelastic in. And then her last eye, they just opened up this incision, put an anterior chamber lens in through the corneal incision, which I don't like to do because it's such a big corneal incision. Gets a lot of astigmatism stuff. So I ended up just suturing this closed and then went up top and did a more proper scleral tunnel. And sorry, let me go back here. And you guys do better scleral tunnels than we do. So Don't look too closely at it. Don't do them too often. And then I used something to put it in called the Sheets Glide. I don't know if you guys have these sort of things, but it's like, I don't know if it's, I don't do enough of these to see if this is really worth it or not. I thought I'd try it on this one with the idea of maybe just holding back more vitreous because I haven't had any vitreous present yet, which was kind of lucky. Our pupil's still nice and round. I've checked the wound several times. There's no vitreous. And then we'll just slide our anterior chamber lens. And I'm not sure what your anterior chamber lenses look like. Do you have is it like a 4-point fixation, kind of probably pretty similar to what we have? The technology in those hasn't changed a lot. But that's sort of what ours looks like. Same lens, yeah. So got that in, and I always, if there's ever any evidence of possible vitreous exposure, I just always suture any wound that I'm worried about. So I did put a little X suture in this just to be sure, because you don't want to have it burp out. I didn't see any vitreous the whole time, so I had to. Her iris wanted to billow forward around the lens, so I had to kind of tuck it back a little bit more at the end. So again, had to do an IA, so I thought I would just do, if I was going to go in and do an IA, I thought I'd just do the vitrector just in case there was any vitreous. Better to have the vitrector in there than to have to go open it up at that point. So, and that's nice little 25 gauge vitrector we have. So do you use your Constellation for your vitrectors? I thought I saw you. Do you use option to do if you need to? Okay, good. Yeah, if you had that, then you have lots of options on size of everything because you could do whatever Retina does. We don't use a Retina vitrector either. We just use the one that's part of the phaco machine. So you get the idea. But that gives you a little bit of idea of one way to help support the capsular bag when it's really loose for those. And those are disposable hooks that aren't horribly expensive compared to, some of the other equipment that we have. All right. Any questions on that? Optic, yes. Yeah, at the very end, I cut out some, but she had a lot of, her pupil didn't come down as well as I'd like it either. I put some myostat in, or myocol in, try to bring her pupil down. So she did have, at the end of surgery, I was able to get the iris to stay completely behind the optic. But when she was seen at the 1 week appointment, she did have some iris overlapping the IOL here. And she had the whole time, she had a lot of that iris. I mean, you kind of see it here. This iris is kind of bulging forward. And so I almost think that maybe even though I didn't see any vitreous, it might have been better to go and do some vitrectomy here to kind of decompress the vitreous and to let the iris fall back more because there was a lot of pressure of the iris bowing forward. And then I left out the PI that you want to do with any anterior chamber lens it goes to.
The orientation of the anterior chamber
lens, yeah.
Which way?
For me, since I don't do a lot of anterior chamber lenses, if I can get it in nice position, I don't care where it is as long as it's in a good. Do you usually rotate them horizontally? Front to back. Yeah, super critical, of course, with an anterior chamber lens because it has vaulting on it too. So you always want to make sure that you know how your lens is supposed to be oriented. My thinking on pretty much all the lenses are designed to be rotated clockwise if you're going to rotate them. Okay. I don't know of any lens that isn't that way. I don't think you know. So everything. So if you look at how this haptic orientation is, this haptic comes over here and then it comes back over here. So you could see if you were to try to rotate this lens counterclockwise, that nub would be just dragging right in the interchamber. So this one is, the way it's set up is it is designed to be rotated. So this is in the proper orientation because it should be rotated that way. But yes, that would cause a lot of iris going forward if you put it upside down, because obviously these lenses are vaulted forward. So they have the haptics push the lens. You don't want this sitting flat at the edge of the iris because it's going to be rubbing against the iris. So they're vaulted forward. So the lens is vaulted forward. And if you were to put it in upside down, it would be vaulted backwards, and it would be pushing through the iris. Most of our one-piece lenses, the one we use injected, have no thing to them, just flat. And so if you put them in upside down, it's not a big deal. It probably changes the A constant slightly of the lens by putting it upside down because of where the powers on the lens are, but it's not going to cause any problem. As opposed to our three-piece lenses, we put in a three-piece lenses. Most all the three-piece lenses I know are vaulted backwards, posteriorly, to push them back into the bag. If you put one of those in upside down, you'll be, oh, I want this lens stay in the bag because it's actually vaulting forward. And those you need to make sure you for sure get in right side up. But if I had a difficult case and put in a one-piece lens, foldable one-piece lens, and it went in upside down, it was a difficult case, and the zonulars are loose and the chamber was shallow, I would touch it. I would just leave it. They're hard to flip over inside the eye unless you have a real myopic patient with a big deep chamber, then you can sometimes do it.
And probably, sir, answering to her question, anyways, that's because you're going to do PI on the superior part, then probably you have option to keep it horizontally oriented. Because if you keep it ups and down, the haptics, you're going to close the PI.
Yeah. Where do you usually put, how do you usually do your PIs?
Yes.
So, but, and what do you do to create the PI? Do you Vanish? So you take grab a little iris with some Calibres or something, pull it out, do a little cut, make a nice proper PI. Okay, yeah, that's a good way to do it.
Just to, sorry.
Yeah.
Can I?
Yeah, please.
Just one point. If you're doing a phaco and wanted to do PI, you have a very nice way to do. There is an option in the machine to do PI, which will have cut rate of 1 CPM.
With the vitractor.
Yes, with the vitractor. Only 1 cut rate in a minute. If you do it with the 5000, it will be like this much of a big hole. So use that one. Just have a little more amount of vacuum, put the cutter downwards, touch it once.
Yeah. Or some people even just take like a 1 millimeter blade and just go straight through the cornea, straight through the iris, come out. Do it that way too. So, okay, I think we have a little bit. Are we? Time is pretty much up. Okay, great. We'll save the we'll have anything, and welcome.
Thanks.